So, like she mentioned, my name is Lisa. I am a clinical application specialist for Centec. I am a PRN clinical application specialist for Centec. I still do work in a level 1 large academic neonatal and pediatric hospital in St. Louis. So I'm a bedside therapist, I am a supervisor and an educator. So like she said, I have a huge passion for training people, and I do a lot of education at work and stuff. So today we're going to talk about restoring gas exchange capacity with utilizing intrapulmonary percussive ventilation therapy, aka IPV therapy. Let's see, I'll move this way. Oops, sorry. Oh, wow, that's sensitive. Let me go back. Okay, so let's talk about some history first. So our patients are becoming much more complex, right? I mean, anybody that's working bedside now, you all know these patients are coming in, they're very sick. They're increasingly common, very challenging, and very complex. In the adult patient population, our hospitalizations for respiratory failure are continuing to grow at a rapid rate of about 10% a year. Oh, wow, that's on automatic. I hate when it does that, sorry. Oh, why is that doing that to me? 20 to 40% of all ICU patients require intubation, and 10% of those patients do fail extubation. So as we know that patient complexity creates a complex clinical complexity, when it comes to managing these patients, the scope becomes very large. In the adult patient population, over 1 million patients are intubated annually. About 4.5 million patients admissions are due to COPD, and about 1.8 million patients are hospitalized for pneumonia. We also are seeing increasing costs in severe asthma admissions, bronchiectasis, VAP diagnosis, and atelectasis. And then for patients requiring mechanical ventilation, the average cost per day is about $2,500. In the pediatric patient population, the patient group is smaller, but still creates a lot of complexity. My current work at the bedside is in a PICU, is in a large, very large PICU, and I can tell you that a lot of our patients are coming in, they're very, very sick. About 100,000 patients, pediatric patients, do require intubation annually. About 40% of all PICU admissions do require intubation, and the length of stay for those patients, for about 35 to 40% of them, is greater than 7 days. What's interesting, though, is our pediatric patients, about 38% of our PICU patients have developmental delay, and this is key to when we're trying to work with these patients, right? It's hard to get patients, pediatric patients, to follow commands. And then also, if they have a developmental delay, any of the anxiety, things like that, it becomes even more complex. So it adds to that complexity. We are also seeing increased admissions for pediatric patients with respiratory failure, VAP, and 93% of all unplanned ICU admissions in the neuromuscular disease patients are due to respiratory infections. And any of you out there that are treating neuromuscular disease patients know that this is a huge problem for these patients, trying to keep them out of the hospital. About a third of our patients, pediatric patients in 2019, required mechanical ventilation for greater than 96 hours, which added the cost of over $200,000. So let's think about, I don't know why this is doing this, I apologize. I don't know why this is doing this to me. So let's think about the patient population in which you all are working. Adult, pediatric, step-down unit. We are constantly battling this balance between, let's hurry up and get them extubated, right? We have to, everybody's doing spontaneous breathing trials to extubate patients. We talk about liberation of mechanical ventilation earlier than later, right? Because prolonged ventilation, we know, creates longer ICU stays, which creates longer hospital stays. ventilator-associated complications due to longer ventilation, and increased mortality. The longer they're ventilated, the greater risk of mortality. But then again, when we extubate them too early and they require reintubation, then again, now you're adding an additional longer length of stay. You're adding that on top of it, right? So you have a longer length of stay, increasing hospital costs. Oh, this is making me, I am so sorry. I don't know why it keeps jumping. It's got this auto. I thought I deleted all that, so I apologize. The research shows, so for all of us that do spontaneous breathing trials, we're looking at heart rate, respiratory rate, SATs, CO2, things like that, right? Possibly a RISB, rapid shallow breathing index, things like that. But what it fails to, what research study has shown us is that evidence suggests that traditional monitoring of spontaneous breathing trial using respiratory rate, O2 sat, blood pressure, heart rate, blood gases is not sufficiently sensitive to detect early signs of load capacity imbalance. One of the things what causes reintubation? And there are several studies here, and the first study tells us that patients who failed extubation had longer duration of mechanical ventilation before they were extubated. The most frequently had ventilator-acquired ICU weakness, had insufficient cough, and abundant secretions. How many of your physicians ask you, how many secretions do they have? Do they ask that question before they extubate? Some do, some don't. They look at that, right? Some do, some don't. A lot of them just look at that SVT and say, well, they passed their spontaneous breathing trial. We can make sure that they stay extubated using other things. Maybe not. So they fail to detect those patients that may fail extubation. Another research study showed that a higher frequency of tracheal suctioning was associated with extubation failure. And then extubation failure was about 36% higher among patients with weak cough versus 6% for patients that had a strong cough. Can extubation failure be predicted? Research studies show us that moderate to copious secretions were found to be an independent predictor of extubation failure, and that an ineffective cough was among the most strongest predictors of reintubation. Do we assess cough before we extubate? Not usually, right? Because we're doing a lot of suctioning. So we don't really assess a patient's cough. Causes related to airway patency and secretion may manifest only after extubation, and then caregivers predicted reintubation with a low sensitivity, and a majority of patients who failed extubation were not considered at a high risk for extubation failure. So some of the challenges here. So this is going to get kind of fun. This is going to be kind of crazy. So you have a patient who has secretion retention. Secretions, they create secretion retention. They have a weak cough. Why do they have a weak cough? Because of their age, possibly. They're in pain. They have an infection. We know infection can cause more secretions, which can cause a weak cough. All these things can add to impaired gas exchange. And mucus plugs can create air trapping, atelectasis, which then, of course, creates an increase in work of breathing. And then back up to the pain. Why are they in pain? Which creates that weak cough. Surgery, chronic pain, trauma, infection creates pain with coughing. Again, then they have secretions. That infection can cause inflammation, hyperflammation. You see where this is all going, right? It's all going to the same spot. Then we have a patient with increased work of breathing who does require intubation or reintubation. Then again, those patients that are intubated, they have sedatives, paralytics. All of these things are all leading back to the very middle here, which is secretion retention, air trapping, and atelectasis. All three of these things can create what we call a triangle, a triad for gas exchange impairment. So let's look at this. All roads to respiratory failure can begin anywhere within this triangle. So what we like to look at, what we like to call is this triad of gas exchange capacity. Think of this triangle. So at the edges, at the top we have secretion retention. At the side here, we have airway, air trapping and hyperinflation. And on that side, we have atelectasis and derecruitment. So think of the triangle. At the very edge, you either have none of these things happening or maybe mild. So as the patient, as the problems become greater, they will close in on themselves. So they become interconnected, okay? So they're separate, but they're interconnected issues, and all of these issues can impair gas exchange, which can lead to patients in respiratory failure. So can we predict, how can we address all three of these components that are separate but interconnected? How can we treat these to increase gas exchange so that we can prevent extubation, extubation failure? We want to predict extubation failure. So what therapies are you currently using in your institution to improve gas exchange? So let's think about some of those things that you're currently using. Chest PT, oscillator, high frequency oscillatory, mechanical insufflation, exsufflation, IPV, OLE, some mucolytics, steroids. You know, we usually have a whole list of menu that we can choose from, right? So we're going to talk about some current shortfalls of traditional therapy. And for this purposes, chest PT, when I refer to chest PT, we're going to be talking about chest percussion and vibration, postural drainage, directed cough, breathing conditioning and exercise, and assisted mucus clearance techniques. So some of the shortfalls for chest PT is many patients can't be positioned. To do adequate chest PT, you have to do all those positions we were taught in respiratory school. Does anybody ever do all of them? No. Patients don't like to be put on their head, do they? They generally don't like that. Not to mention the fact that it can create a lot of pain. Some patients can't be struck manually, right? If you have osteoporosis, brittle bones, can cause bruising, scoliosis, any spinal neck injury, often requires the patient comprehension and participation. As mentioned, I have a lot of years under my belt. So we used to do, anybody remember how to do actual chest vibration? Right? You got to make them take a deep breath in and exhale and do the vibration as they give that long exhale. Anybody ever do that anymore? Not really, right? It takes a lot of cooperation of your patient. Oh, I hate when this does this. I am so sorry. I just hope it doesn't jump to the next slide again. The sessions can be long, 20 to 40 minutes. Does not resolve atelectasis. Chest PT will not treat atelectasis. It cannot access those peripheral secretions. And there's no evidence that chest PT will improve resting lung function and can prevent non-invasive ventilation or decrease patients' length of stay. And that's been proven in the research. One of this, I find this interesting statement. Because of its historical prominence, I don't know why this, I am really sorry, y'all. I hate when it manually moves. Because of its historical prominence and frequency of use, chest PT has been mistakenly classified as the gold standard. And that is a statement of the AARC Clinical Practice Guidelines, which is our go-to, right? So let's look at high frequency chest wall oscillation and mechanical insufflation and exsufflation. This is your vest and cough assist, right? So positives of high frequency chest wall oscillation, much more effective than manual chest PT. Why? Because you can access all the lung fields at one time, which is great. Less caregiver fatigue. Can be used frequently to loosen secretions, but it cannot replicate and does nothing for a patient with ineffective cough. It may loosen the secretions, but it's not going to move them out and forward. Cannot use it on patients with surgery and burn. Can be somewhat painful for some women. Mechanical insufflation and exsufflation, aka cough assist, very easy to use with a mask, mouthpiece, or an airway. is used frequently for patients that have an ineffective or no cough. But again, this cannot loosen secretions. It may bring up stuff that you've loosened. So a lot of times you have to do these therapies together, right? So a lot of times we're doing combo therapy, which can create a long time. It takes your therapist a long time to do the therapy. It only works well if the patient needs to cough. One of my most frustrating things for my therapists in our PICU is when they order Q2 or Q4 cough assist. First off, it's very taxing on the patient. Secondly, if they don't need to cough, if there's nothing there, why are we doing it, right? So that can be a problem. So again, let's look at this triangle, this triad of gas exchange capacity. We talked about secretion retention, air trapping and hyperinflation, and atelectasis. So if I have a patient that has secretion retention, what am I going to treat him with? Possible cough assist, maybe chest PT, maybe the vest. Possibly give them a mucolytic, and then of course along with that mucolytic I have to give them a bronchodilator. If they have air trapping or hyperinflation, I may have to treat them with some inhaled steroids. Then if they have atelectasis, now I have to throw in some PEP therapy because none of those others that we talked about are going to treat atelectasis, so I have to give them some PEP therapy or incentive spirometry, and we all know incentive spirometry is actually, I hate to say it's kind of worthless. Actually, the AARC clinical practice guidelines has completely removed IS from their treatment regimen. So what if we talked about how can we break up and move out secretions to reinflate the lung, and we're going to have to treat the, work around the, reduce and decrease the work of breathing. You're going to have to do all of these things. So if you have a patient that has all of these, you're going to have to do all of that combo therapy. So this is where IPV therapy can come into play. It has a unique mechanism of action. The movement of the venturi within that phasotron. So this is called the phasotron. Let's see if I do this. Where's the light? Oh, well, that's not good. So the phasotron is moving within the venturi is moving within the actual phasotron itself. It can work around obstructions, recruit the lung, and break up secretions and move them out. What it does is the percussion, the movement of the venturi, enhances that percussive burst that effectively can break up secretions and mucus plugs. I call it like chipping away, right? It chips away at those mucus plugs. The air entrainment, the venturi movement, dynamically responds to each individual patient's airway resistance and can effectively recruit the lung. And then the high velocity flow can access those distal airways beyond the obstructions, beyond the secretion, mobilize those secretions away from the airway wall, and that high velocity flow, that expiratory, enables expiratory flow, which is necessary to move those secretions outward and forward and upward. And then of course it does have a nebulizer. You never want to use this dry because there's a lot of flow, so you always want to use it with at least some saline. So this is our triad before, right? We would have to, if we needed to treat all of these things, we would have to do all this therapy. But what about, I can use one therapy to treat? How would this look to your patient? How would this impact your therapist's workflow? Huge cost savings, huge impact on your patient, huge impact on your therapist. So let's look at some evidence. Okay, IPV can remove secretions. In our first study, we see the patient population over here on my right. It's looking at some Duchenne's neuromuscular disease patients whose sputum was measured after receiving assisted mucus clearance techniques, and which included manual cough assist and forced expiratory techniques, that forced expiratory, push, and plus IPV, and then it compared patients with assisted mucus techniques without IPV. And if you can see here that what they did is they looked at the amount of secretions that were removed before and after, and they looked at the weight of the secretions. And the patients that were treated with IPV had a 68% increase in the weight. So the weight of the sputum was greater than 6 grams, where the weight of the sputum for patients that did not receive the IPV was about 4.5 grams. So that can be significant for some patients. So in this study, we talked about that IPV therapy can remove secretions by the percussion. It breaks up secretions, can access the distal airways and obstruction and get behind those, the airway wall, create that expiratory flow. So let's look at, this is a study of CF patients. And what they did was they compared IPV, manual chest PT, and high-frequency chest wall oscillation, and they looked at the weight of the sputum. Now, this isn't significant because, as y'all know, CFers have the most sticky, elastic secretions on Earth, right? So what they did was, as you can see, that the weight of secretions for the CF group that were treated with IPV was greater than almost 7 grams. And what's interesting, though, I find interesting is that the PD group actually got more heavier weight than the vest group, which seems kind of interesting, right? So let's look, we talked about how IPV can work around inflammation. COPD patients with whom air trapping and hyperinflation are common, they failed better when treated with IPV. So what this group wanted to look at is to treat patients with IPV and treat patients on traditional therapy without IPV. And their primary outcome was to look at the need for how the patients advanced to needing non-invasive ventilation. And these are mild respiratory acidosis patients. So the patients that were treated with IPV, 6 out of 17 of them, only, sorry, let me rephrase that. 35% of the patients that were not treated with IPV required advancement to non-invasive ventilation, and none of the patients treated with IPV needed advancement to non-invasive ventilation. They also looked at length of stay, and the patients treated with standard therapy had a greater than 1 day length of stay, which may not sound like a big deal, right? 1 more day. But 1 more day is another day that you have a free bed for another admission, right? So as we all know, we're all crunched for beds. The secondary outcomes, though, was looking at the physiologic parameters. The patients treated with IPV had a decrease in their CO2, an increase in their O2, and a decrease in their respiratory rate. So they had to feel better. Researchers also determined that IPV is a safe technique and may prevent further deterioration in patients with COPD. This is another way to look at COPD. We talked about how it can improve expiratory flow. As we know, patients with COPD have a problem with expiratory flow, right? They can get it in, but they can't get it out. That's what causes all of their higher residual volume. So the way this square box chart works is that each blue dot, see, now it doesn't want to advance for me. Okay, each blue dot represents a patient, okay? And we have expiratory flow improved and expiratory flow not improved. And what you'll see here is none of the patients treated with IPV had a decrease in their expiratory flow limitation. More than them had a greater increase. So they measured it pre and post. And again, the secondary outcomes for these patients were that CO2 decreased, O2 increased, SATs increased, and the respiratory rate increased. In addition, if you can see, it's kind of in this yellow, so it may be hard to see, is that after IPV, their expiratory flow limitation decreased almost in half, which is huge for a COPD patient. Okay, this is, so we also mentioned that IPV can recruit the lungs. So how does this happen? And let's look at a pediatric patient. So this study was done with pediatric patients using a, what they call an atelectasis score. And what they did is they looked at patients pre and post IPV, 0 being that they had a complete resolution of their atelectasis, and 4 is complete collapse. So the patients post IPV had a resolution of their atelectasis scores by greater than half, almost one and a half times greater. So IPV compared to other modalities, so compared to chest PT, IPV therapy has been demonstrated to better gas exchange, expiratory volume, improve health status. Compared to high-frequency chest wall oscillation is associated with greater breathing strength, more favorable sputum and COPD scores. And then compared to OLE, OLE sometimes gets conferred to IPV, which it's not. IPV therapy has been demonstrated to have greater secretion mobilization in bench testing. So let's look at IPV compared to chest PT. So the IPV is in the gold and the chest PT is in the blue. So this is looking at your patients with COPD. These are severe COPD patients with the DLCO scores and the residual volume. And we talked about that, about how patients with COPD, their residual volume is a big problem for them, right? So patients treated with IPV had a decrease in their residual volume and had a significant improvement in their FEV1, which again for COPD patients can be a big problem. Secondary outcome was looking at gas exchange and looking at their SpO2, and the patients treated with IPV had an improvement in their PO2. So let's look at breathing strength. So how does it improve breathing strength? Again, this is the same study looking at very severe and severe COPD patients, looking at MIP and MEP, maximum inspiratory pressure, and looking at maximum expiratory pressure. So because we can create that flow, that expiratory flow, that will help create that maximal inspiratory pressure and that maximal expiratory pressure. And as you can see, both pre and post, compared to the vest, that the IPV had a very significant improvement in both the MIP and MEP for our patients in this study. Looking at the BCSS, which is your breathlessness, cough, and sputum scale scores, and your CAT scores. Now, these are looking at COPD patients and their activities of daily living, because let's face it, it's all about improving their life, right? We want to improve their ability to walk, ability to go to the grocery store, things like that. That's what's important to them. The numbers on their PFTs don't mean anything to them. What's important to them is, can I go to the grocery store? Can I go shopping? Things like that. So if we can decrease their breathlessness score and increase their and decrease their CAT scores, these are scores looking at their activities of daily living, and this equates to improvement of their activities of daily living. Again, these are severe and very severe COPD patients we're looking at here. So this was a bench study where the researchers, and this is a relatively recent study. So OLE is oscillation and lung recruitment, lung expansion therapy. Again, sometimes it's been misinterpreted as IPV. Some people call OLE and IPV the same thing, but they're not the same, because IPV has the proprietary technology with the expiratory flow. And in similar settings, they looked at patients that, this was a bench study, so it was simulated mucus with and without a ventilator, and the OLE was similar settings as the IPV, I'm going to put that back, did not improve as much, did not remove as much simulated mucus as the IPV did in the bench study. This was true with both invasive and non-invasive ventilation. So we talked about earlier that neuromuscular disease patients, 93% of unplanned admissions for these neuromuscular disease patients due to respiratory infections. What if we could treat them at home with IPV therapy, and so this was a study looking at length of stay and this was a standard, patients received standard treatment, and patients received IPV, had a lower incidence of non-invasive ventilation and a shorter hospital length of stay. In addition, that's this study here, but they also looked at, they wanted to treat patients at home. So the top study is looking at patients treated pre-home, and none of the patients treated with IPV required hospitalization due to respiratory infections. And in COPD patients with mild respiratory acidosis, compared using standard therapy compared to IPV therapy, they had zero of the patients treated with IPV needed non-invasive ventilation, and their length of stay, again, was greater than about 1 day. Again, doesn't sound like a big deal, but to the bean counters at the hospital, that's a big deal, right? So we need to get these patients home. So IPV can improve gas exchange and compliance. So looking at patients before and after IPV, they looked at COPD patients and they showed improvement with their PF ratios and their dynamic compliance. And this is just a trajectory of their improvement. Again, looking at secondary outcomes, which are important to all of us, is their CO2 dropped, their PO2 increased, and their respiratory rate also dropped. So how does IPV, how can it improve outcomes in worker breathing and lung function? So what this is looking at patients as their own control, okay? Treating them with IPV. So the blue bar is patient's spontaneous breathing, okay? And then they treated the patient with IPV, and the 4 bars after each patient was looking, the 4 bars are looking at different settings of the IPV. So different percussion and different pressure settings. And what they looked at is they looked at the diaphragmatic product of the product time of the diaphragm. That's the work of the diaphragm. And as you can see, compared to the patients compared to spontaneous ventilation, they, with each setting, dramatically decreased their diaphragmatic work, increased their tidal volume, and then intrinsic PEEP. Again, this is on 10. Now these were stable COPD patients, which is a good thing. But we know COPD patients have a lot of intrinsic PEEP, right? Because their residual volume is usually high. So if we can offload that RV, drop their intrinsic PEEP. And again, each patient was compared. So I'm going to put this back because so I have this little tagline. I'm from Missouri, okay? And our saying is show me. So I love research. I think research is so important. But what does it really mean for me, my patient, when I'm treating them, right? What am I actually doing? I want to see proof in the pudding. I want to see what it's really happening for my patient. So I have a couple of case studies here, and I want us to take a good look at them. So the first one here is this patient is out of Florida. The first x-ray on my far right, your left, is after 2 therapeutic bronchoscopies. So this patient has been bronch twice, okay? And usually patients that have a complete collapse, that's the first thing they want to do is bronch them. So this patient was treated with 1 hour of continuous IPV therapy. And that is the patient's improvement in their x-ray, almost a complete resolution of their atelectasis on the left lung. Not complete, probably needed a few more treatments, but almost a complete resolution of their atelectasis. This is a patient out of Tacoma, Washington, that the pre-x-ray, and look at the vent settings. I think the vent settings are also very important to look at. So the patient's pressure control, rated 20. The PIP was set to 15. Patient's PIP was 15, pressure support at 10, PEEP at 12. FiO2 100%, and the patient's tidal volume with that was only 300. So the patient did receive 1 bronch, but also received 5 IPV treatments. IPV treatments, depending on your institution, can run anywhere between about 15 to 20 minutes. Where I work, our treatments are 15 minutes long we usually do about, what we do is we usually do about 5 different settings, moving the patient from one portion to another, and but every institution is slightly different. After 5 treatments, the X-rays, you can see the costophrenic angle on the left now again. You can also see almost complete resolution of the atelectasis. But look at the vent settings. Now they were able to change this patient to volume control, but the tidal volume doubled. Now the PIP, what I would like to have known with this study is what was the plateau pressure, right? See, because now the patient was in volume. I'm interested to know what the patient's plateau pressure is. But significant also is the fact that the PEEP was able to be cut in half, and the FiO2 dropped dramatically down from 100% to 45%. So this is huge in treatment of this patient, right? Hopefully his intubation didn't last long after that. This is another one which I think is very important. This patient was treated with BiPAP. So this was a non-invasive patient who has a complete collapse of this lung. I mean, that's obvious, right? But this patient was treated with IPV through a BiPAP mask. After 1 IPV treatment, just 1, we have the left lung is completely open. Now we still have some work to do, but this was only after 1 treatment, okay? So like I said, I'm from Missouri. The proof is in the pudding. I want to see what it's doing for my patient. So, of course, now it's going to be stuck. What did I do? I'm going to hit next. What did I end up hitting? I ended up hitting the mouse. All right. So IPV has a long history of being safe and well tolerated across many patient populations and care settings. These are some research studies. These are some comments from the publishers. It's effective. Evidence has shown us. So we're looking at that triad again. Evidence has shown us that IPV can decrease length of stay, resolve atelectasis faster than manual chest PT, mobilize secretions more effectively than OLE, improve global gas exchange, respiratory rate, and compliance, reduce antibiotic use and respiratory hospitalizations as part of a preventative regimen, and resolve hyperinflation, expiratory flow limitation, and air trapping, aka intrinsic PEEP in our COPD patients, and reduce the likelihood of COPD exacerbation. So in summary, respiratory patients, we know, are increasingly common, challenging, and costly in both children and adults. Gas exchange impairment in these patients is caused by the 3 interconnected, again, what we call the triangle of gas exchange impairment: secretion retention, atelectasis, hyperinflation, and air trapping. Current therapies sometimes fall short by failing to address all 3. You have to piecemeal it, right? You have to pick off a menu. You have to have the a la carte. We want everything included. IPV therapy helps relieve these 3 things caused by gas exchange impairment through airflow characteristics provided by a proprietary technology. And I think that's an important thing that we need to discuss, is that IPV is safe, efficient, well tolerated across a diverse patient population, care settings, delivery interfaces, and due to its unique mechanism of action that comprehensively improves gas exchange capacity. Again, my name is Lisa, and we have all of the citations listed here if you would like them. But this thing is very sensitive, isn't it? So if you have any questions, I'm happy to answer. No? Thank you.